Good afternoon. I am Dr. Doug Evans, Chair of the Department of Surgery at the Medical College of Wisconsin, and welcome to our weekly update on innovations and programs in the Department of Surgery. Today's topic is cardiac surgery, and I'm thrilled to have Dr. Paul Pearson with me today. Paul, welcome.
Thank you.
Paul is a graduate of the Mayo Medical School, where he received his MD and his PhD degrees. He then did his surgical training at Virginia Mason Medical Center in Seattle and returned to the Mayo Clinic for cardiothoracic surgery training. That's an additional anywhere from 2 to 3 years of training after general surgery training. Most recently, Paul came to us as Division Chief of Adult Cardiothoracic Surgery from the North Shore University Health System, just north of Chicago. And Paul, we're thrilled that you joined us and are leading the way for our programs in cardiac and thoracic surgery. I know you have a specific interest in adult cardiac surgery, especially valve surgery. And maybe you can talk to our audience a little bit about the cardiac valves. I think the people have certainly heard about the aortic and mitral valves, and why they may require repair, and some of the really neat, new, innovative techniques that you're using to repair heart valves.
Well, that's great. That is a big interest of mine. As you know, we've been doing heart valve replacement surgery now since 1960. So we've been doing that for 57 years. As you can probably appreciate, over 57 years, the technology has improved, the processes have improved, and procedures now are very, very safe. The big drawbacks of open heart surgery, however, are that it's very invasive and the recovery process takes a long time. Because of that, we've developed new techniques where we can give people new heart valves without open heart surgery, without having to make an incision on the chest. This is part of a multidisciplinary project that we're working with here at the Medical College of Wisconsin, Frederick Hospital, with our colleagues in interventional cardiology. For example, the most common heart valve abnormality today is aortic stenosis. Aortic stenosis occurs when the valve gets too tight. The leaflets become like a door that's jammed.
So this is the aortic valve is the one that leaves the left ventricle going out to the rest of the body.
Exactly. The left ventricle is the main pumping chamber of the heart, fills with oxygenated blood from the lungs. After the left ventricle is filled, it squeezes and pushes all that blood out your aorta to support your blood pressure. There's a valve between the left ventricle and the aorta called the aortic valve. The aortic valve has a very simple job. When the heart squeezes, the valve is supposed to open to allow the blood to escape. When the heart relaxes, the valve is supposed to close to prevent the blood from going back inside the heart. Normally, the leaflets of that valve are very, very supple, like rose petals, open and close with no effort. Very strong, but very supple. However, many of our patients, and the most common heart valve problem in the United States, is that valve becomes like a door that's jammed. For some reason, in certain patients, calcium deposits in those leaflets. And so, just like a door that's jammed, it takes the heart a lot of effort to get the valve moving, and it doesn't open all the way. Unfortunately, there are no medicines that can treat that. There are no medicines that can even keep it from progressing. It will progress and take a person's life. Now, before 1960, if you were to have the diagnosis of aortic stenosis, that was like having the diagnosis of cancer that they couldn't cure. That all changed with the development of open heart surgery. Open heart surgery really revolutionized our ability to treat patients with valve problems. And here at the Medical College, we have the most advanced technology now to use open heart surgery to treat those types of problems.
And really, open heart surgery involves putting a patient on cardiopulmonary bypass.
Yes.
So that you may or may not arrest the heart.
Yes.
And stop it from beating so that you can work on it.
Yes.
And then you just restart it again.
Exactly. And that's a very safe technique in this day and age. When the first open heart surgeries were performed, the mortality rate was 50%. Now the risk of surgery is single digits, 1 and 2%. But again, it's a very invasive procedure, and it requires a long recovery process.
So you still have to open the chest, typically through a median sternotomy, or
yes,
splitting the sternum.
There are a number of different approaches that we use here at the Medical College, depending if a patient has isolated valve disease or there are other issues with the heart that need to be corrected. We can do our conventional surgical approach, the median sternotomy. We can do small mini thoracotomy approaches. But all of them require cardiopulmonary bypass, and no matter how small the incision is, it's still open heart surgery. But working with our colleagues in cardiology, we're now able to offer a technique where we can give patients new aortic valves without an incision on the chest, without having to use a heart-lung circuit, without having to stop the heart. A procedure is called transcatheter aortic valve replacement, but we go by the acronym TAVR, T-A-V-R. With TAVR, we put a small plastic tube in the artery in the leg. Using an X-ray machine, we then pass that small plastic tube up across the aortic valve that's too tight. Using that small plastic tube, we actually deploy a stent, which is a big metal cage, inside the valve that's too tight, and it literally forces the valve open and pins the leaflets of the valve open between the stent and the wall of the aorta. Suspended in that stent is a new tissue heart valve that starts functioning right away.
Wow.
So we can give a person a new tissue heart valve without an incision on the chest, without having to use a heart-lung circuit, without having to stop the heart. And when we can use the artery in the leg as access, we don't even put a patient to sleep for the procedure. We just numb up the skin in the groin. We give them a little medicine into the vein to relax them. But in that way, we can avoid all the risks and side effects of a general anesthesia. From the time a person goes into the procedure room till the time they leave with their new heart valve, it's usually about 2 hours. Our average patient would spend about 24 hours in the hospital before going home and go back to their normal activities. I know you're an avid sailor. The oldest patient that I was involved treating was 100 years old when he had his procedure.
Wow.
Still actively sailing a sailboat on Lake Michigan, and then this past year he had had his 103rd birthday.
Wow.
So with these minimally invasive techniques that we use here at the medical college, we're able to reach out and treat people who would not be good candidates for conventional surgery just from a recovery standpoint.
Yeah. So within that stent, so the stent is, if you will, it's packaged into that delivery catheter,
Yes.
so that it's small enough, and then you release it under
Exactly.
X-ray guidance, and then the leaflets just respond to the normal pressure of the heart, correct?
Yes.
So
the leaflets function just like a door blowing in the wind, and they operate by pressure. And one of the things I like to do in the office is I'll show patients a model of our TAVR valve, and it's quite large. And I'll tell them that we have a device that can crimp that valve down over a high-pressure balloon so that it's smaller than my pen. So we can get it in position, expand the high-pressure balloon, the stent expands, and then they have a new functioning valve.
wow.
Yeah.
Wow, that's amazing. Now, when would you, if you have a patient with aortic stenosis, when would you not do, if you will, the catheter procedure or the TAVR procedure, and when would you operate on the patient?
That's a very good question. Currently in the United States, TAVR is only approved commercially. That means patients can be treated outside of a research protocol if you're intermediate risk or above. So low-risk patients, the only way that a patient can currently be treated if they're a low-risk surgical patient with TAVR is if they're part of a research protocol. And the reason for that is that the FDA says open heart surgery for low-risk patients, it's very safe, it's proven, you've been doing it for 57 years. It would almost be unethical to offer that to a low-risk patient unless we have clinical trials that show that it's either not inferior or it's superior to conventional surgery to treat aortic stenosis. In my opinion, in 5 years, aortic stenosis will be treated primarily with TAVR, and if patients for some reason are not a candidate for TAVR, then open heart surgery will be a second line therapy for them.
So how often is aortic stenosis combined with some other abnormality in the heart, a blood vessel problem or something else that requires both to be fixed at the same time?
That's also a good question, because we can also correct other problems with interventional techniques. So if a person has a blockage in one artery on the heart and they have aortic stenosis, our approach here at the medical college is that we'll bring the patient into the interventional cardiology lab, we'll put a stent in their coronary artery that's too tight, we'll take a balloon and kind of crack their aortic valve open. That's called a balloon aortic valvuloplasty, and that's a temporizing measure. We'll send them home, let them recover for a month, and then bring them back for their TAVR. So both procedures don't require an anesthesia, they don't require a long hospital stay. But if you get into more complex problems, such as they have a mitral valve, which is another valve on the left side of the heart that's abnormal, and they have an aortic valve problem. If they have an aneurysm, which is an abnormal enlargement of a blood vessel, for those types of patients, we still offer conventional surgical techniques because we don't yet at this time have the tools necessary to treat those in minimally invasive ways.
I know this is a complicated subject, but in general for the listeners, because I think everyone is familiar with stents put in the coronary arteries.
Yes.
For people with angina or exertional chest pain, when in general are stents the right answer, and when is a conventional operation with traditional surgical bypass seem to be more beneficial for the patient?
There are many studies that have answered that very question. If somebody, and when you talk about coronary disease, we have two coronary arteries. However, if you talk to an interventional cardiologist or a cardiac surgeon, they'll talk about three vessel disease. And you say, well, where do you get the three vessels from the two arteries? Well, the left coronary artery, which is the most important, immediately branches into two large branches. So we consider each of those their own separate artery. So if a person has three vessel disease, if a person is diabetic, if a person has diffuse disease, if a person's heart function is not normal, there are many studies that show that coronary bypass grafting has a survival advantage than multi-vessel stenting. And so we're very lucky here at the Medical College and Froedtert Hospital. We have a weekly interdisciplinary conference where interventional cardiology, general cardiology, echocardiology, cardiac surgery, we all sit around a table and we discuss these cases.
Sure.
And we each discuss from our own perspectives and based on the medical literature, what's the most appropriate therapy. And I think that's one of the benefits of being in an academic institution that people don't appreciate. That rather than being a provider who's got a hammer and everything he looks at is a nail, here we have a toolbox filled with tools, and so we can offer the patient what's best for them.
Fantastic. I know, lastly, maybe we conclude with one other of your real passions, and that's trying to improve global health systems. I know that we've talked about this before, about the importance of trying to, if you will, maximize the safety, efficiency, and the results of cardiac surgery programs. And obviously, there's now been a huge amount of literature, especially in surgery, to show that to some degree surgery is not that much different than basketball. The more you practice shooting foul shots, probably the better you are at it. So that those centers that perform a larger number of procedures and have a larger number of patients, so that everyone from the nurse to the perfusionist running the heart and lung machine, to the surgeon, to the scrub nurses, everyone becomes a little bit more experienced. How would you, if the world would listen to you and you could do anything you want, how would you organize that, for example, in southeastern Wisconsin?
Well, that's a very good question. As you know, where I practice near Chicago, the greater Chicago area has more open heart surgery programs than the entire country of Canada. Wow. And so you have lots of low volume programs, and you're exactly right. Volumes are somewhat of a surrogate for quality. Now, there are some good small programs, but as a rule, as you said, using the basketball analogy, the more cases an institution can do, the stronger their program can be because of that. What we're looking for to do here at the Medical College is to have several regional centers where there'll be high-volume centers for cardiac surgery. Obviously, Froedtert Hospital here is always going to be our center for heart failure and transplantation. We have the most experienced heart transplant surgeon on staff here. We have a heart transplant surgeon on staff here who was on the team that put the first artificial heart in a man. And so we have a very, very experienced team with those types of procedures. And what we would envision and we're working toward is that our satellite centers, and we provide cardiac surgery services all the way up in central Wisconsin. Faculty from our division go up there and do surgery. Is that the low-risk cases that we know can be done in that environment are done, and can be done safely there with good outcomes, we'll do that. However, to use your sports analogy, when you need a special teams, You'll then send that patient down here to Frederick in the medical college, and surgeons that have special abilities in that particular area can take care of the patient.
What a great opportunity to try to really do that. I know that there's been so much written and talked about with regard to large system-based programs that allow patients to, when possible, be treated closer to home, the so-called right place at the right time for the right patient, and then also have a complete integration so the patient who really has a critical illness and needs someone oftentimes at the most inopportune time, they can be taken care of as well. So,
Well, and I think in your own field, pancreatic cancer and pancreatic resection, that's clearly shown that specialized centers, that operation should only be done in specialized centers with very experienced surgeons.
great. Well, Paul, thanks so much. Really a great session, tremendous information for those of us who have listened, and your contact information will appear on the next few slides. So thanks so much, and thank you all for joining us.